Good morning, everyone. Sorry. First of all, I'd like to thank Dr. Mustafa Sulaiman for inviting me for this really nice meeting. I'm going to speak today about neurological complication after TEVAR. I'm going to speak about spinal cord ischemia and stroke. Spinal cord ischemia, we know the blood supply of the spine comes from the intercostal lumbars and subclavian and internal iliac arteries. But the most important is the artery of Adam-Wickes, which will come from T8 to T12. The factor for CSI in TEVAR is the length of the operation, hypotension, the extent of thoracic aortic coverage, especially if we cover T8 to T12. The indication for intervention, do we do it for aneurysm or dissection, female gender, and inadequate collateral circulation because of left subclavian coverage without bypass or prior AAA repair. But in general, the CSI after TEVAR is about 3 to 8% only compared with the open, which is about 5 to 20%. There's difference in CSI between open and endovascular. In open, the CSI happen because of the cross-clamping and prolonged hypotension. So we prevent it by retrograde perfusion, cooling, CSF drainage, intercostal reimplantation. In general, in open repair, we see immediate more than we see a delayed CSI in the patient. In the TEVAR, there's no cross-clamping, no and limited hypotension, but the problem, we don't have the legacy of reimplantation of the intercostal artery. How we prevent it in TEVAR? By limited coverage of the important arteries, especially T8 to T12, and maintenance good perfusion to the spine. And in general, delay spinal cord ischemia is more common after TEVAR than an open. How we prevent CSI? Early diagnosis is very critical. We need to increase the spinal perfusion by reduce the CSF pressure less than 10 and increase the mean arterial pressure more than 90. We need to identify and avoid covering the important spinal arteries, especially T8 to T12, and CT angiogram could be sometimes very helpful. What we saw from the last case, we leave a type 3 endoleak. So if we do complicated thoracoabdominal aortic aneurysm, we leave off the branch open to keep perfusion to the sac, and we come later on to close this type 3 endoleak. And lastly, we treat reperfusion injury by naloxone and scavengers. So when we do CSF drainage, some people do it routinely, but we like to do selectively. If we cover the thoracic aorta more than 20 centimeters, if patient has a prior AAA repair, if we cover left subclavian artery without bypass, and if the patient has an occluded internal iliac artery. And therapeutic if patient develop any signs of numbness, tingling, or paralysis after surgery. This is very important protocol. When you send patient to the ICU, it's very important to give this protocol for the ICU team. You need to zero spinal pressure monitor to the level of spine because ICU people, they used to level all the line to the level of the heart. We need to keep the spinal drainage less than 10. Don't drain more than 20 cc per hour because you may get subarachnoid hemorrhage or fatal brain stem herniation. If CSF drain bloody anytime, turn it off. We need to keep spinal drainage at least for 2-3 days. So even if you come next day and there's no neurological symptoms, you need still to keep it at least for 2 or 3 days and avoid hypotension. If patient develop a delay neurological deficit, then you have to check. If patient has a CSF drainage, then be sure that it's working. It's not king, it's not thrombose. If patient doesn't have a CSF drainage, then you need to insert it as soon as possible. And all studies show that the sooner you insert the CSF drainage, the quicker the patient will recover from his neurological deficit. You need to increase the arterial pressure more than 90. You need to keep good spinal cord perfusion because we know it's equal to main arterial pressure minus the ICP. You need to avoid hypertension. It's very important to write in your protocol to keep saturation more than 95% and hemoglobin more than 10. So in summary, CSI remain a major morbidity after TEVAR. Also, the incidence is less than open repair. High-risk patient include the female who has, patient has a long coverage of thoracic aorta, extensive aneurysmal disease, prior AAA and left subclavian artery coverage. Careful preoperative planning and identification of critical artery is very important. How we prevent it? By limit lengths of the coverage, keep mean arterial pressure more than 90, employ CSF drainage and keep CSF pressure less than 10, and elective revascularization of left subclavian artery. Now we move to the stroke. This is a very nice paper published recently. They look at the silent cerebral infarction, which by definition is a brain injury detected incidentally on imaging MRI without acute neurological dysfunction. Why is it important to look at that? Because they found that the silent cerebral infarction can increase the risk of future stroke, can cause dementia, depression, cognitive impairment, and early death. And when they use TCD to look at the hits during the procedure, they found that the patient, he get embolization in every step of the procedure. But the majority of the embolization happened during contrast injection and stent deployment. Also, they noticed that the older age of the group, they have a significant positive decline in their neurocognitive test. So they do worse than younger people. What the pathology could be an air, thrombus, or particle from the aortic arch. How we can protect from the stroke by patient selection to avoid shaggy aorta, giving statin and stop smoking. We need to minimize the catheter and wire implant manipulation. Try to keep an ACT at least between 250 to 350. Some people, they use temporary occlusion of carotid artery or left subclavian artery. Recently, we started using CO2 flushing to get the air out from around the graft. And again, recently, we started using the CEP devices. We have about 5 available in the market. The one we used commonly now is a Sentinel cerebral embolic protection. This is the only FDA-approved device. It's go through the 6 French go through the radial artery. It's very simple. It has 2 filters, 1 stay in intimate artery and 1 stay in the left subclavian artery. Like this one of our cases, you can see the 2 filter, 1 in the left intimate artery and 1 in the left common carotid artery. And this is during the procedure, and you can see all this debris being removed during the procedure. And this study showed that if you use Sentinel device, you decrease all stroke and mortality in 7 days. The other device is the Edward embolic detector. It is CA market, and also it has a radial axis. So in conclusion, high rate of cerebral embolization and neurocognitive decline happen after TEVAR. Brain injury after TEVAR is more common than we thought. All TEVAR had a TCT detected cerebral embolizations, and overall brain injury is 81%. But luckily, clinical stroke only 8%, and silent infarction only about 68%. Thank you very much.